Good afternoon and welcome. My name is Ruth and I'm the marketing manager here at Kimal. Over the last 12 weeks, we've been talking about Torapase as a solution for the prevention of CIED infection. And the engagement that we've had from everybody has been not just encouraging, but also really exciting to explore the potential and the possibilities of this solution. So first of all, just to thank you to everybody that's engaged with us on this journey so far. This is the last webinar in this series, and today we're going to be talking about a slightly different subject and talking about wall blocks in CIED-related surgical procedures. Joining me again today is Benito Baldoff, consultant cardiologist, and there will be opportunity, as always, after the session to submit your questions, and we'll do a live Q&A. You can use the Ask Us box on screen now to submit your questions. Any we don't have opportunity to answer today, we will come back to you straight after the webinar by way of email. You can also use the Contact Us box on screen if you would like to engage with us further. If you want more information about Benito or his work, then please submit your request using that. Benito, without further ado, I'm going to hand over to you.
Well, thank you, Ruth, for the kind introduction. These are my disclosures. So let's get right to the start with this really intriguing way of local anesthesia we'll be talking about today. This is Torapase. It's a liquid solution designed to prevent CIED infection. As you can clearly see, this is a typical picture about a CIED infection or of a CIED infection ongoing with a generator box protrusion through the skin. So I'm going to be talking about the scope of the problem, and this is redundant because it's the first slides of every webinar. CIED-related surgical procedure rates are rising, and CIED infection rates are rising disproportionately. And I'm referring to literature you're all familiar with. They have seen an increase in CIED-related surgical procedures in the observation time of 100%. At the same time, CIED infection rates were rising disproportionately at 200%. What are the reasons for CIED infection rates? As we know, patients are older due to better work of us cardiologists or cardiothoracic surgeons, and therefore they display more comorbidities when they're undergoing CIED-related surgical procedures. Also, living longer with CIED means more box exchanges and more complex devices are used than just some years ago. They're in general heavier and bulkier and display more leads when implanted or handled. Therefore, they need a longer duration to be implanted or handled. And if we cardiologists conduct the procedure, we are more likely to conduct this in the EP or the catheter laboratory rather than the operational theater, which is a different kind of setting in terms of sterility. And I suspect a shift in antibiotic resistance in endemic species. So general considerations prior to the intervention regarding CIED-related surgical procedures. I encourage you to consider using thoracic wall blocks. So in post-surgical pain, you're always facing limiting the recovery of a patient because the incidence of pulmonary complications as for hyperventilation, atelectasis, and therefore maybe pneumonia or infection itself increase perioperative morbidity. Altogether, this increases length of stay in the hospital. So therefore, adequate treatment of surgical chest pain with minimal administration of anesthetics is very important in any CIED-related surgical procedure. So this is going to be about thoracic wall blocks. They're an easy non-sterile procedure. They're relatively young. I think the first manuscripts were published around 2011 and 2014, always looking into breast augmentation or memory surgery related to cancer, and they've shown to be improving outcome. Also, in regard of a CIED-related surgical procedure, they ease the access to creation of remote pockets, talking about, for example, submuscular pockets or intermuscular pockets. Okay. Another local anesthesia or way of local anesthesia is Tumescent local anesthesia. There has been publications, just recent publications regarding, for example, CIED implants. It's an easy sterile procedure, meaning that the patient is already prepared and draped and washed down for the procedure itself. It improves outcome. This is data from CIED, as I said. And there's no need for general anesthesia in CIED-related surgical procedures. Therefore, you do not need, you can conduct your CIED implant or handling CIED or conducting related surgical procedures without general anesthesia, just in conscious sedation. These are the structures we're dealing with when we're conducting thoracic wall blocks, so it's back to the plain blocks. Specifically, these structures we're addressing with our blocks. So there's different kinds of thoracic wall plain blocks, and I'm going to be referring to the, in my eyes, most important ones, which is PEX1, Pectoralis block 1, PEX2, Serratus plain block, or transversus thoracic plain block, which used to be called peristernal plain block, which is a way of intercostal nerve block from the ventral side. So it's this family of plain blocks. Talking about the thoracic wall plain blocks, we need measures to help us to identify the structures. Talking about sonoanatomy, we need a high-frequency linear ultrasound probe, so the one that you would use for vascular structures. In a parasagittal position on or lateral to the mid-clavicular line. So basically, you'll be putting your probe in this position, and then you can move it down towards rib 3 and 4 for PEX 1 and 2 block, and for medial to the mid-clavicular line for transversus thoracic plain block, and the combination of PEX 1 or 2 and transversus thoracic plain block. Parasagittal to the spine for dorsal intercostal costal plain block, and almost coronal frontal lateral to mid-axillary line for Serratus plain block lateral approach. I'm going to be showing some pictures or some photos later on to show you how this is conducted. And I want to encourage you also to go online and watch videos, tutorial videos, if you're not already conducting thoracic wall plain blocks. They're really helpful. Which drugs are to be used? Well, it's about 30 to 50 mils or cc of local anesthetic, and they're displayed in order of longevity here. So lidocaine is 1 to 3 hours, bupivacaine is 2 to 8 hours, and ropivacaine is in a concentration of 0.375% is 4 to 12 hours. And if you want to add up to longevity of these local anesthetics, you want to add up with 100 micrograms of clonidine, which enhance longevity up to 24 hours. This has been well tested. For talking about thoracic wall blocks and Pectoralis 1 block, this is very good for primary pacemaker implants or handling or box exchanges in PPMs in subcutaneous position. The structures we're addressing are the Pectoralis major and the Pectoralis minor, and we're addressing the fascia in between those muscles. Here you can see an ultrasound picture of the pectoralis major and the pectoralis minor. And from the right upper angle, there's the needle, which is highlighted now, coming into the fascia between these two muscles. As borderline structure, you can identify the artery and the rib down below. Now, this is the pectoralis major. Here is the pectoralis minor. And you can already see the spread between the two muscles with just as little as 5 cc of local anesthetic administered. And this is here. So already a desired spread, and you want to infiltrate with as much as 10 to 30 mils. Now you can see it's the same picture with a little more of local anesthetic infiltrated between the two structures. Again, here is the needle highlighted. It's a little thin. I don't know if you can all see it. Coming from the right upper corner into the structure. The next is the pectoralis major. Now here's the pectoralis minor. Again, we have the borderline structures as for the artery and the rib. And this is all anesthetic now. This is the pectoralis 1 block, which helps you whenever you're conducting a primary pacemaker implant in subcutaneous position. Now, referring to the pectoralis 2 block, it's basically pectoralis 1 block in combination with a block between pectoralis minor and serratus. This pectoralis 2 block can be used in any CIED in submuscular position, especially in SICDs in combination with the transversus plane block and maybe a serratus plane block, but this later. So the structures we are addressing with our needle and the probe are the pectoralis major, minor, and the serratus anterior. Here again is a picture, and we have the borderline structures as for the 4th rib. Here you can see the pectoralis major, the pectoralis minor, and the serratus anterior. And again, this is this parasaccate line, mid-clavicular line, where you go and place your probe, and then you slide towards the 4th rib, and what you want to do is move it outside, and then you see this picture. Again, I want to encourage you to go and go online and check it online. There's good video tutorials from anesthesiologists conducting these kind of wall blocks. Here's the borderline structure as for the artery. Now here you can see the needle advancing from the upper right corner of the picture, or this ultrasound picture, advancing towards the fascia or the plane between pectoralis minor and serratus anterior. Now here's the needle indicated with the green line and the pectoralis major. There's the pectoralis minor, and this is the serratus anterior. And now we can see this is all lung. So we have to really be careful whenever we're advancing the needle in this area. Pneumothorax could be a side effect. So really important is to be watching the whole procedure live with your probe when you're advancing the needle towards the final structures where you want to infiltrate with your local anesthetic. Now referring to the serratus plane lateral approach, whenever you're conducting a CIED implant in an intermuscular position, especially SICD intermuscular between latissimus dorsi and serratus, in combination with a transversus for the shock coil, and the pectoralis to cover the whole area maybe. We're advancing our needle to infiltrate between latissimus and serratus. These are the borderline structures. Here you can see the positioning of the patient and the lateral approach of the syringe with the needle advancing between these two structures, latissimus and serratus. Now referring to a special parasternal block we can use in CIED implants in combination with pectoralis 2 and or serratus plane in lateral position whenever we're implanting in an intermuscular position in the mid-axillary line for an CIED. And the structures we're dealing with in the thoracic transversus plane block or the parasternal block is the musculus transversus and the musculus intercostalis internus. So this is a drawing of the structure. This is the transversus muscle indicated as orange. Then we have the artery as borderline, the internal thoracic vessels as borderline structure, and behind this is the intercostalis internus, drawn in gray. And this is another ultrasound picture where you can see the needle advancing from the right upper corner. You see the intercostal costal muscle and the transversus thoracic muscle, and here you can see the desired spread with the first 5 cc of local anesthetic introduced into or between these muscles. And this is a very powerful local anesthetic or a way to conduct your local infiltration, because it gives you a lot of time without pain and for the patient. And whoever conducted an CIED implant before, even under general anesthesia, you can tell that the patients are undergoing a painful intervention when you're advancing the trocar for implantation of the shock coil in the sternal area, because this is just barely above the muscle. And you know, when you do resuscitation, that's the point where you want to annoy the patient to have him wake up. So this is there's many nerves in this area, and therefore you want to have the patient covered as good as possible when conducting an CIED implant. And therefore I suggest you use this kind of local anesthesia. As you can see below, there's indicated that this is the pleura, and so again you want to cover the whole procedure with your ultrasound probe to be safe and secure. I was talking about Tumescent local anesthesia as counterpart or as supplementary local anesthesia form when dealing with implants. Tumescent local anesthesia has been introduced to CIED implants and has been checked, and there's actual literature published showing better outcome. It's a nerve blockage to larger areas of the skin and subcutaneous tissue by direct infiltration of large volumes of diluted local anesthetic solution into the subcutaneous fat. So really what we're doing is infiltrating with almost 250 mils or cc in the sternal area, another 250 cc in the tunnel or in the area of the tunnel from the pocket of the CIED to the xiphoid. And then another 500 cc in the area where the generator is implanted. So altogether almost 1 liter or a liter of liquid in the subcutaneous fat. So this might be an alternative since it had been checked and in an RCT just recently published with better outcome. But in my eyes, it's an alternative to vessel plain blocks because if you're dealing with patients and you'll be infiltrating 1 liter of liquid in addition to thoracic wall blocks, I think this is just too much. So I see it more in a way as for an alternative. So I'm going to be reporting a bit about this as well, since it has been published just recently. And this is what you're dealing with, the drugs you're dealing with. So it's 1 liter of sodium chloride physiologic, 50 cc of lidocaine, 12.5 cc of sodium bicarbonate, and 1 cc of epinephrine. It had been checked this way. In other settings, local anesthesia or anesthetics mixed with epinephrine are not used anymore, but in this setting, it had been checked this way. So as you can see, a lot of liquid we're infiltrating with, but it had been checked. This is referring to what I said whenever conducting Tumescent local anesthesia in an CIED implant. You use a special kind of needle which is perforated, and there you can see the amount of liquid you will be infiltrating in these areas, so it's a lot. So here's pictures. Again, we're talking about a large area affected, covered with incision foil. There's sternum written, so there's an indication that this is the sternal area where the infiltration with the 2E needle is conducted, the first infiltration with 250 cc. So along the where the trocar is introduced later on, these 250 cc are introduced in sterile technique with double gloving, as you can see, and 250 cc is infiltrated in this area. You can also mix, I forgot about this, you can also mix with corticosteroids, which seem to be enhancing the progress or the process. So this is the next picture showing, I think we went over one, yeah. So this is the next picture where we have the infiltration in the pocket area. I think we jumped over the pictures of the tunneling as well, but you can imagine this, and it's indicated in the pictures. There's 250 cc in the tunnel area where you're tunneling from the pocket or from the xiphoid towards the pocket later on to recover the shock coil and pull it back from the pocket towards the xiphoid area. And here's the picture about 500 cc infiltration with local anesthetics in the pocket area in the mid-axillary line of this patient. Okay, a lot of pictures here. Okay, again, referring to toropace, this has not been, so I've not been talking a lot about toropace at this webinar, but again, toropace is designed to prevent CIED infections, and clearly talking about this last intervention now, in terms of CIED implant, toropace is basically designed for this kind of intervention. Just think about cooling the pocket when you're implanting the device. It's safe. It will be fully absorbed. It does not display any tissue toxicity or organ toxicity, even when administered at some 100 cc inside the pocket. It's ultimately absorbed after degradation into amino acid compound, and thus create a favorable pH range inside the CIED pocket to prevent CIED infection in the longer course. Again, the chart that you're all familiar with, the activity of Toropase within 2 hours in terms of log regression of colony-forming units in endemic species that we face day in, day out in CIED infections. Thank you very much, Ruth. I think we have some questions regarding the thoracic wall plane blocks. This was super fast, I have to admit. I encourage you all to watch this on video tutorials. Again, it's very intriguing how they conduct this and very interesting. You do not need to be an anesthesiologist to conduct these kind of wall blocks. You just need to know your way around with ultrasound. That's all. Okay.
Thanks, Benito. Yeah, we do have a few questions. In regards to thoracic wall blocks in particular, could you conduct these in any patient?
Yes, I think so. I mean, if there's any, there's no known side effects for local administration of these kind of local anesthetics, other than maybe allergy. I don't think that there's a problem with administering this in patients that do not have a known allergy to any of these substances. I also think if you were not to puncture any vessel and to infiltrate a vessel with these local anesthetics, I think you're on the safe side and you can use it in any patient regardless of the intervention relating to any CIED, or also in other patients you're handling, for example, ICU patients that you need to administer or to need to implant any drainage or stuff like that. Also in port patients and all other patients that maybe need central access, venous access or something. You can use these kind of wall blocks in basically all patients you want to be using them on.
I think you've probably covered the next one, but it was just, are there any contraindications to wall blocks? So you mentioned allergy as a contraindication. Is there anything else that you would flag specifically?
Well, it's, I'm not an anesthesiologist, but I think other than allergy, at this point, nothing comes to my mind. Obviously, some of these local anesthetics display side effects when administered in the wrong way. You're familiar with for lidocaine and bupivacaine, but ropivacaine, it seems to be pretty safe in these contexts. So also in terms of longevity, I think these kind of anesthetics are well tested and well known. And again, I want to be referring to some of my first slides. I mean, if you have someone who has undergone any kind of thoracic surgery in terms of a CIED-related surgical procedure or a sternotomy in heart, in cabbage or something like this, if you could imagine if there's a pain while breathing, that hypoventilation could be the result. And whenever there's hypoventilation in a hospital setting, we must fear infection or pneumonia in the end, because there's no good ventilation of all areas of the lung. And so we want to prevent this basically. And in different cardiothoracic surgical procedures, this has been proven safe and effective in terms of better outcome for the patients. So I want to encourage you to use it in basically every CIED-related surgical procedure, because it's really fast and easy, and you do not use, other than in Tumescent local anesthesia, where you're not near any plane with your huge syringe and needle. In these local applying these local anesthetics, they're you use basically small needles. So you have to be aware of the fact that when you puncture the pleura, the result will not be a huge pneumothorax in case. And again, you're watching the procedure the whole time with your probe. So just advance the needle very slowly, identify the right structures, and go ahead. I mean, I want to encourage you really to do this, because this helps a lot during a CIED-related surgical procedure and any other surgical procedure that is conducted somewhere in this area.
Thanks, Benito. I'm going to combine the next two questions together. The first part is, how long has Toropace been commercially available? And then, is there any data available on the safety and efficacy of the product?
Well, Toropace has been commercially available from the summer of 2019 in the field of CIED-related surgical procedures. To my knowledge, Toropace is certified also for the use in orthopedic prosthetic joint related surgical procedures. And to my knowledge, it is used in off-label in lung transplant centers during the transplant of the organ, and as inhalatory vapor afterwards against herpes virus infections or the prevention of those, and as prevention for bacterial and fungal pneumonia. And as it is also used off-label or as compassionate use in frail patients where CIED-related infections are occurring and an extract procedure is not conducted, or the patient denies it or neglects it, and also as compassionate use in, to my knowledge, in left and right ventricular heart assist devices, extracorporeal and intracorporeal, and I've been referring to this in a prior webinar for the driveline infections in pediatric and non-pediatric patients with bridge to therapy and destination therapy, L or HVAD.
The second part of that question, Benito, was, is there data available on the safety and efficacy?
Well, there's three studies actually ongoing with, to this point, to my knowledge, it's around 1,500 participants. Until this point, there has not been an infection or any side effect or any adverse effect. The data is at this moment formally audited and will be going into publication. I cannot say when this will be, but it will be somewhere in this year, so 2021. So yeah, but so far no data.
Thank you, Benito. I think in terms of questions, we'll leave it there. That's probably a good point to say that, you know, this is the last webinar in this series, but the plan is that we'll run another series perhaps in the autumn, so when we've got some of that data and some of that research that we can share. So watch this space for further information. In terms of everybody that's joined us today, thank you. And a big thank you, as I said earlier, to everybody that's engaged with us over the last few months. And Benito, to you, a very big thank you for joining us for each of the webinars and sharing your work. It's been really valuable and a great insight, so thank you. So in terms of myself, thank you to everybody. Thank you to everybody that's made this webinar series possible, and goodbye from today.
Well, thank you, Ruth. Very kind of you. Thank you all. It has been a wonderful 12 weeks now, incredible during this pandemic also. Thank you for having me and sharing my stories about Toropace. You know, I'm a true enthusiast again, but I think it has a great future. and I hope it all goes well. Also during this pandemic, let's see where it leads. Thank you again, and bye-bye.